Hi, this is Chadi Alraies, Denver, Colorado, CVI 2019. With me is Dr. Dmitriy Feldman. He is Associate Professor of Medicine at Cornell Medical College, and he's the Director of Endovascular Center at Cornell Medical Center. Welcome, Dmitry. Always nice to talk to you.
Thank you. Pleasure.
Yesterday we had a nice debate about radial versus femoral. There's a big push for radial first for less bleeding, but I think interventionist has a role for femoral. What's your point?
Yeah, we had a great debate yesterday. Sunil Rao and myself were talking about the role of radial versus femoral, and Sunil was taking a role that radial should be used in everyone, and my counterpoint was that femoral still has a role. But debate has really shifted over the last few years from femoral versus radial to where does femoral fit now. I think most of us, myself included, agree that radial first is the way to go. But there are situations in certain patient scenarios, anatomic and clinical, where we think femoral still has a role, and so we need to be careful and perhaps a little bit thoughtful about defining where that role is. So certainly, you know, when you fail at radial access, you have to convert. When you have intractable radial spasm, when you have complex patients with AV fistulas, you could go contralateral, but those are the patients you want to think about. But also very complex PCI, where you're going to need a large bore access, more than 7-8 French. Still, we're doing a lot of endovascular as well as TAVR procedures. So we have to be understanding where the role of the femoral access still is, and there's definitely still a role.
Right. So in the large bore database, there's always vascular complication due to the large bore. So do you think it's the large bore is a problem, or getting access for the large bore is a problem?
That's a good question. I think as we're moving towards more and more radial diagnostic and interventional procedures, we do need to make sure that the femoral skill and what we teach our fellows is maintained.
Exactly.
And we're getting a little bit into a problematic situation because we are doing more and more complex PCIs. And more complex PCIs are being reserved for femoral access. At the same time, we're training fewer femoral procedures. And so it's not surprising that we're dealing with a situation where potentially we may have what people call a radial paradox, where people who are doing too many radial interventions are now having more vascular complications with femoral intervention. So the radial vascular and bleeding complications have come down, but the femoral complications have gone up. And that's what we really need to avoid. Not everybody is in the same place. You know, there are a lot of radialists who were trained femorally, but are now doing mostly radial procedures. There are a lot of interventionalists who are doing mostly radial, but still doing a lot of large bore access.
Right.
But I think people who are vulnerable are the new fellows who are being trained mostly radial, and in their practice they're doing mostly radial. So when they need to go femoral, for large bore access, for impellers, for complex PCI, for TAVRs, for EVARs, this is where the problem arises. And I think that we need to be very careful, and so we need to hone on the femoral skills. We need to make sure that we do a good job with ultrasound guidance, with micropuncture, with vascular closures. Those are all still skills that are very important.
That was my next question to you. What is your tips about successful vascular femoral access?
Personally, I don't use a lot of ultrasound. We mostly use the micropuncture, but so very careful micropuncture technique using fluoroscopic guidance, visualizing the wire very carefully under fluoroscopy, taking angiography after access is obtained, making sure patient is appropriate for vascular closure. I think all those techniques are extremely important.
Do you use a 4 French microcatheter to inject, or you just go straight as long as you are hitting in the mid-femoral head?
If I'm happy with where I hit, I'll just go in with the micropuncture catheter and take the access. If I'm not happy or if I'm hesitant, I'll use the introducer technique where you inject and take a picture.
All right. Yeah. So it sounds like for all the operators, especially fellows in early career there, you should don't forget the femoral. Radial first, don't forget the femoral.
Yeah, I think especially, there's still a lot of controversy. The ACC, as you know, presented the Safari STEMI trial. And I think what we're learning over time is radial first is a very good strategy. And I think we have so much data about reduction in bleeding complications, vascular complication, patient comfort, length of stay. All those things are extremely important. But femoral still has a role, and if you are a very experienced femoral operator, then you can get very good outcomes, as we've seen in Safari STEMI, both in terms of mortality, both in terms of bleeding, and they will be somewhat similar to the radial.
That will be a nice skill to have for bailout if the radial fails, or as you said, for largebore.
Exactly.
Thank you so much, Dmitry, for your time. This is a great discussion. Please watch this video and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Thank you.
Thank you.